We want to invite the first speaker, Dr. Joanne Shan, to talk about pulsing or probing for Meibomian gland disease.
Management of Meibomian gland disease, pulsing or probing. I have no financial interest or relations to disclose, though I do use all three devices. Pulsing or probing, let's learn the ABCs. For vectored thermal pulsation, VTP, intense pulse light, IPL, which is usually combined with manual meibomian gland expression, MGX, and meibomian gland intraductal probing, IDP. So in January 2017, CEDARS, the Cornea External Disease and Refractive Society Dysfunctional Tear Syndrome Panel, came out with recommendations for obstructive meibomian gland disease. This included thermal pulsation, IPL, and probing. Later that year, TFAS-DUCE report came out recommending two of those options, thermal pulsation and IPL. And earlier this year, ASCRS Corneal Clinical Committee recommended thermal pulsation and IPL, and for refractive cases, intraductal probing. So let's compare these briefly. Vector thermal pulsation begins with topical anesthetic, and then usually a manual exfoliation of the eyelid margins with a foreign body spud, followed by automated expression with actuators. Intense pulse light with meibomian gland expression starts out again with topical anesthetic, shielding the eyes from IPL exposure, and then 2 passes of IPL from tragus to tragus. And sometimes upper lid treatment is done as well with specialized handpieces. This is followed by manual expression with Q-tips or specialized forceps, and then 2 days of NSAIDs or topical steroids. Intraductal probing starts out with compounded topical 8% lidocaine and jojoba oil, followed by 1 to 6 millimeter blunt tip probes for intraductal placement, and then usually followed by with manual expression, possibly intraductal steroid injection, and then topical steroids. So, does one method have superiority over the other? Let's look to the literature. Reviewing English studies from 2010 to the present, the most data we find for prospective case-controlled studies are for vector thermal pulsation, and next for intense pulse light, and only found 2 of these case-controlled prospective studies for intraductal probing. So let's review vector thermal pulsation. There were 7 studies. They are done in the US, Germany, Singapore, USA, and China. And the groups really randomized the LipiFlow versus other lid warming techniques. And one study in 2018 looking at doxycycline, BID to daily maintenance for the 3-month duration. The average month of follow-up was 1 to 12 months. And in the LipiFlow group, we found symptoms improved as well as meibomian gland yielding liquid secretions. What did not change was the atrophy on meibography in 2 of the studies reported. Let's look at the IPL studies. There were 6, and these case-controlled studies really were divided in 3 that looked at IPL only without the expression versus controls, versus IPL with meibomian gland expression versus expression only. So all these studies, they show that the symptoms improve and the tear breakup time improves. One study in 2017 showed that tear inflammatory markers decreased. One study from China in 2018 showed that meibomian gland structure by confocal improved, but the overall meibum and atrophy did not improve. And unfortunately, there was not improvement of Demodex consistently with IPL. And all these studies actually have been performed outside the United States. One other interesting article I found on blepharitic keratoconjunctivitis, BKC, was in a group of Chinese patients with recurrent moderate to severe blepharitic keratoconjunctivitis that can be seen with MGD. They were treated with steroids and antibiotics, and then 1 month later, the patients self-selected into a treatment versus control group, either IPL with meibomian gland expression or meibomian gland expression only. There was actually no recurrence of BKC in the treatment group. However, 18% of the control group had recurrence over the 4-month treatment trial. The OSDI improved in both groups, and the meibomian gland expressibility and quality of meibum improved more so in the treatment group. However, the self-selected treatment group had less meibomian gland atrophy when reviewed. Let's look at probing. As we said, there's a paucity of data. I found 2 articles, one fluorometholone and fluorometholone versus probing, and the other conventional versus conventional with probing. Conventional therapy being lid hygiene, warm compresses, omega-3 fatty acids, topical Cipro, and oral azithromycin. So both of those studies showed a higher level of improvement in Meibomian quality and a faster rate of expressibility in those groups. However, by the end of the trial, both the groups improved equally in symptoms. So overall, what are the physical limitations? For vector thermal pulsation, this one-size-fits-all actuator is difficult in tight eyelids or very floppy eyelids to stay in place. IPL with Meibomian gland expression, we can't treat deeply pigmented patients or those with active skin lesions, and there's concern about eyelash loss if you're treating inappropriately or don't have eye protection. For intraductal probing, you need the compounded lidocaine to make your patient happy. We are limited by the limitation in the prospective follow-up. For vector thermal pulsation, it's up to 12 months, IPL 9 months, and only 3 months in the intraductal probing and 6 months in the case series. So in conclusion, the CEDARS and ASCRS protocols recommend both pulsing and probing. The TFAS DUES 2, pulsing only. For vector thermal pulsation IPL, the control studies show significant improvement in dry eye parameters as compared to conventional treatment. However, we're limited by small cohort size, short follow-up, and a significant IPL Asian cohort. Intraductal probing controlled studies showed no endpoint treatment advantage versus conventional treatment in the 2 trials at 3 months. I didn't find any comparison studies. I would like to see vector thermal pulsation versus IPL or MGX, or IPL versus intraductal probing, or even intraductal probing versus expression alone. There isn't data to say which technology is most effective or safest across the board. We do need long-term data to include monitoring of Meibomian gland atrophy. Thank you for your attention.